How many people are familiar with the Bethesda system? Okay, good, because that's important. I'm representing a group of people who are trying to figure out how to introduce HPV testing into co-testing or into screening and management. And I'm not sure that's relevant to everybody. It's relevant certainly to the US, but I'll tell you some thinking that was influential in recent guideline meetings that we've had. New screening guidelines that came out in the beginning of the year recommend HPV and cytology co-testing. Now, around 90% of women will be HPV negative, PAP negative. And that's great, because they can have an extended screening interval. Certainly 3 years, maybe 5 years or more, depending on your view of things. But around 10% of women will have some kind of positive screening test. Either the HPV will be positive, or the cytology will be ascus or greater. And we'll have novel combinations occurring a lot. And how do we manage every combination of cytologic, virologic, and histologic abnormality over time? How do we move to something new? So in the face of the complexity, how do you make guidelines? Now, this is the point of my talk, and if you take this away, then I've succeeded. Ask yourself how guidelines are made. Question them, because when you get into the heart of them, there's a lot of arbitrary and a lot of impressionistic things that happen with the experts that are sitting there. And you really need to question the truth of them as we go forward, not take them on face value. That's the main point of this. We came up with an approach. It may not be right. I'm not even sure that it's the best approach, but it's the best that I've come up with my friends so far. And so we're using risk as the guiding and unifying principle. We're saying that the risk of cervical CIN3 in cancer, which we call CIN3+, can be used to boil down all this complex battery of tests and all the algorithm books and all the decisions, and that there should be consistency, regardless of which combination of tests are done. I'm going to use 5-year risk of CIN3+ for this discussion. It could be that it's also really important to consider immediate risk of CIN3+. It's somewhat arbitrary, but you're going to have to follow me on that one, and I'm happy to talk about that particular point later. There's a lot of assumptions, but still the main principle is that equal management of equal risks makes sense. If something is about as risky as something else, you should be doing about the same thing for it. That ensures simplified and consistent management, and I'm going to try to demonstrate that, and we'll see how it goes. Now, the data are from Kaiser Permanente, Northern California, and thanks to Walter Kinney for setting this up, and Phil Castle, and this is from their, what we call guidelines, the Guidelines Project. Kaiser has been using co-testing since 2003. We have over 1 million women. It's 1.4 million women, 1 million over age 30 and older, undergoing co-testing, many outcomes, including, unfortunately, some cancers. And there's a very high follow-up rate. And the guidelines at Kaiser are similar to the ASCCP guidelines, so they're useful in terms of follow-up. So here's the question. Say you have these new combinations because you're doing HPV testing and you're doing cytology. So you could either be HPV positive, these three, or HPV negative. These are ordered in terms of CIN3 risk over 5 years. Now, the PAP can be, and I took off the high-grade ones because they're not controversial. High-grade PAPs go to colposcopy. ASCUS, AGC, ASCH, HSIL, they go to colpo, and we don't need to worry about them right now. That's all going to be regardless of HPV status. So, however, for the lower grade ones, there's questions. So you can have ASCUS, HPV positive, LSIL, HPV positive, PAP negative, which is a very common category. This is the frequency in the population. 3.5% of women are going to have this new combination. There could be HPV negative LSIL, which is a discrepant thing. The cytology is saying there's HPV there, but the molecular test is saying there isn't. That's not very common. HPV negative ascus, an equivocal pap that is HPV negative. HPV negative pap negative, which is the most reassuring, and as I said, around 92% in Kaiser have this reassuring combination. What do we do, though? How do you decide with these new combinations what to do? And the principle is to compare the new things to the old things, to what we're already doing. And what we're already doing and familiar with is cytology alone. We either send people, based on cytology alone, to colposcopy. We return them in the United States for 6 to 12-month return for repeat testing, repeat screening. We do a 3-year return for certain things, and we don't do a 5-year return for virtually anything yet in the United States. But those are the limited sort of choices of what you can do. Now, they're associated with specific cytologies. LSIL goes immediately to colpo in the United States. The frequency of this 1% of findings in Kaiser, sometimes it's more in a younger population. Remember, these are 30 and older women. That's a risk of around 5.3%. So for the risk of around 5.3%, we are sending people to colpo, anything greater than around 5%. That's at Kaiser. Now, in other populations, it could be a little higher or lower, but we're using the Kaiser model now. And then you see for ascus, which is only about half as much risk because only about half is HPV positive, that's a 2.6% risk, and we're returning that for 6 to 12-month return. Now, much lower, a tenth as risky, is the very common finding of a normal pap, a negative pap smear, a negative cytology. That's a 3-year return. Now, here's the key slide. It's really the only major slide left. Oh, this is the slide. We are comparing, it looks very complicated, but really is just putting together that first chart with the second chart and creating risk bands. This is something that Phil had in the American Journal of Obstetrics and Gynecology. When was that, Phil? 08, in 08, and we're just expanding on that. So if you look at the immediate colposcopy band, LSIL is around 5.3%. So anything riskier should go to immediate colpo. So that means that HPV positive ascus, which is actually a little bit riskier than HPV positive LSIL, should go to immediate colpo. And there's an intellectual equality there that means that we feel satisfied making that decision for the new combinations. Now, for HPV positive, PAP negative, it's troublesome because over 5 years, the risk is 4.5%. And that's a large category of people. Now, you could say that we should put them immediately to colposcopy because it's almost up to 5.3%. Where is the break point between immediate colposcopy and returning for 6 to 12 months? If you did that, you would really increase the amount of colposcopy, and the decision was made to break it right here and say that this is a 6 to 12 month return, and that HPV negative LSIL, which is even less, would also be a 6 to 12 month return, and that's the decision that has been taken. Now, a 3-year return is PAP negative. We just said that. PAP negative comes back in the US now at 3 years. Well, what about HPV negative ascus? It's similar in magnitude and risk to a normal PAP alone, and the decision was taken to consider a 3-year return on that. And a 5-year return is only possible now for HPV negative, PAP negative. And why is that? Because the risk is substantially lower than a negative PAP alone. So we felt it was possible to extend the screening intervals. Now, people will immediately say, and it's true, that your population could be different than Kaiser, using different HPV or cytology testing followed up differently. That's absolutely true. We expect that this benchmarking approach, where we're taking the new tests and benchmarking them, if that's a term that's familiar to you, what we already know, will yield the same bands for equal management as we see using Kaiser data, but we're really looking to other experiences and hoping for new big data sets that will let us validate this approach. And we feel like an example would be that for HPV positive ascus, that it's like LSIL everywhere that I've studied, and therefore you should treat them the same way. And I'm very eager to hear people come up to me afterwards. It'd be great to hear other people's reactions to whether that's true where you are too, that these are basically the same equivalences. The other thing that I won't go into today is that we also applied this benchmarking to risk, this comparability, this equality principle for post-colposcopy and for post-treatment. We're reasoning that regardless of where you are in the screening and management pathway, same risks should be followed the same way. So if somebody's been treated and their risk gets very low again, they should be treated the same way as if they are in a low-risk initial setting. And it's really an attempt to introduce risk across the entire spectrum of what we do in cervical cancer screening and management. And I look forward to comments on how you do that, how in your places you're making guidelines, and on what basis. Just opinion or intuition, or whether there's really a systematic system that's guiding it. So thank you.